Namaskaram everyone. Post-COVID, there has been an upsurge in the number of cases of autism, as has been noticed by myself and by many other pediatricians also. And hence, I decided to make a video on the consensus statement by the Indian Academy of Pediatrics on the evaluation and management of autism spectrum disorder or autism, as we'll see further. These guidelines were, however, published in the year 2017, that is the pre-COVID era. So I have included the important recommendation made by the American Academy of Pediatrics in the year January 2020. I think all general pediatricians and everyone must be aware of this pertinent disease which we are facing an upsurge of. So basically, what is the difference between autism and autistic spectrum disorder? Autism is basically a new term for autistic spectrum disorder, as has been defined by the Diagnostic and Statistical Manual 5th edition by the American Psychiatrists Association. Autistic spectrum disorder is an older term which was used by the DSM-4 and all. The World Health Organization's International Classification of Diseases 11th, that is the latest edition, still uses this term, but it does not classify it further into different other diseases, as we'll see later. Autism has two characteristic features basically. Lack of social communication and interaction is the first and important one, and the second is restrictive, repetitive patterns of behavior or stereotypies, which they are typically known as. Autistic spectrum disorder, as it was earlier referred to, had comprised of three disorders. Asperger's syndrome, like when we were doing post-graduation, we studied these three aspects: Asperger's syndrome, childhood disintegrative disorder, and pervasive developmental disorder not otherwise specified. So basically they now say that we call autism as autistic spectrum disorder because it is a kind of spectrum disorder. That is, it has varied manifestations and it can manifest in varied manner in different children. Pathophysiologically, it has a multifactorial origin. Actually, there is a very complex interaction among multiple genes which do not change the DNA sequencing, but they are heritable, as along with environment and epigenetic factors. The earliest symptom of autism is absence of normal behavior and not the presence of an abnormal one. That is, absence of the normal warm, joyful nature of the child. Also, there is absence of reciprocating expressions, like when you're talking to the child, he would not reciprocate to you, he would not respond to you. And there is absence of to and fro babbling and jargoning. It appears that the baby is very good, quiet, and undemanding. The other key signs of autism include parental concerns that my child does not hear when he is called his name, or he does not respond whenever he is asked to do something. Second, extremes of temperament and behaviors, like sometimes the child is markedly irritable to sometimes he is absolutely passive and non-responding. And also regression of social skills and or speech. So all children should be screened by a standardized autism screening tool I shall be discussing later at 18 and 24 months of age as per this consensus statement. If the child is more than 18 months of age and has symptoms, then you must administer the ASD specific screening tool right away. If, however, the child is less than 18 months of age, you must first evaluate the social communication skills of the child, whether or not the child is achieving the language milestones up to date or not. Commence parental education and reschedule the next visit after 3 months if the child is less than 12 months of age, or after 1 month if the child's age is more than 12 months. And if the concerns still persist, it is only then that you must administer the ASD specific screening tool. Now, if the result of screening tool is positive or concerning, then in that case you must continue parental education, refer the child for comprehensive autistic spectrum disorder evaluation, initiate an early intervention program, evaluate hearing status, and schedule the next follow-up visit after at least a month. So Up till this step, I think all general pediatricians will be able to do. The American Academy of Pediatrics in 2020 has said that developmental surveillance of every child should be done at every health supervision visit. In addition, screening tests should also be done at 9th month, 18th month, and 24th or 30th month, whichever is there with the child. Now I shall be discussing three important screening tools. The modified checklist for autism in toddlers, a revised one has now come. It is freely available and downloadable. It is there in multiple languages and has to be completed by parents. It takes around 10 minutes for them to complete. And you can see the questions are very simple in this. Like, does your child enjoy being swung, bounced on your knee, etc.? Does your child take interest in other children? Does your child like climbing on things like upstairs, etc.? So this uses a simple scoring procedure based on pass or failed items. And if the child screens positive, a follow-up interview is conducted, including only those items on which the child had failed initially. Therefore, this decreases the possibility of false positive results. Now, if the total score is somewhere between 0 to 2, you can screen again the child after he is 24 months of age. If it is between 3 to 7, then you can call the child for follow-up. And if the score is between 8 to 20, you must immediately refer the child for a comprehensive diagnostic evaluation of autistic spectrum disorder and possible early intervention as early as required as possible. The other tool is social communication questionnaire, which is available in many Indian languages. And another screening tool is autism behavior checklist. The most handy is MCHAT-R. Now, children may present with delays in core developmental areas in the first year of life. So, what are the core developmental areas? These are gross motor, fine motor, language, cognitive and intellectual, and social and emotional. But sometimes these symptoms are subtle and not everyone might be able to recognize. Or sometimes what happens is that the children develop the symptoms which do not progress further, they develop a plateau and it later becomes apparent in life. So, what the statement says is that in the early developmental period, the symptoms may be present but they might not be apparent. By 2 years of age, the symptoms usually become apparent because this is the time when the social demands of a baby exceed its limited capabilities. Sometimes, when the symptoms are very mild, it may take around 4 to 6 years of age to manifest the same. Around one-fourth to one-third of children achieve early language milestones, but then they have regression of language, communication, and of social skills between 15 and 24 months of age. Around two-thirds of patients with autistic spectrum disorder present with they never acquire communication skills during the first 2 years of life. So these points are very important to be remembered. Other key features are sensory and motor impairments, deficits in play and imitation skills, and gastrointestinal symptoms. Common comorbidities are intellectual or language impairment, medical disorders like seizures, known genetic conditions, neurodevelopmental, behavioral, and/or mental health comorbidities, for example, hyperactivity and inattention, motor deficits like abnormal gait, clumsiness, toe walking, or hypotonia, anxiety, depression, behavioral dysregulation, sleep problems, which may affect daytime functioning, gastrointestinal feeding and nutritional problems like constipation, restricted diet, catatonia, macrocephaly, and delays in acquisition of self-help skills like toileting, dressing, hygiene, etc. So after the screening tests, we now come on to the diagnostic tools which help in diagnosing ASD. The most commonly used one is Inkland Diagnostic Tool, or INDT ASD. Basically, it has high content validity, internal consistency. It is very good in short because these are statistical terms which every one of us might not understand and which If anyone interested, I shall explain it further to him or her. Then Indian scale for assessment of autism. A cutoff score of more than 70 is considered to be positive. It basically helps in identifying and certifying autism in 3 to 9-year-old kids. It has high sensitivity, specificity, and good positive predictive value. Childhood autism rating scale. It has a cutoff score is more than equal to 33, has high sensitivity and specificity. It is advised for diagnostic use in Indian population. Autism Diagnostic Observation Schedule is available in both Hindi and Bengali languages. An autism diagnostic interview, it has significant cost and usage time implications, though it has good sensitivity and specificity. So for diagnosis, you must do a thorough physical examination, a hearing and vision screening as a prerequisite, assessment of cognitive ability and adaptive skills for planning further intervention with respect to observed social communication difficulties relative to overall development. Measurements of receptive and expressive vocabulary using a tool like REALS, that is Receptive Expressive Emergent Language Scale. Social pragmatic skills are evaluated clinically or via a scale like ADOS, which I discussed in the earlier scene. Occupational and physical therapy evaluations. Additional evaluations are recommended based on family history and examination and the presence of any dysmorphic features if they are present, like hypothyroidism, homocystinuria, head injury, fetal alcohol syndrome, or chromosomal abnormalities. EEG needs to be done if especially the child has aphasia to rule out the Landau-Kleffner syndrome. Genetic testing including G-banded karyotype, fragile X testing, or a chromosomal microarray if clinically indicated. For example, MECP2 gene is implicated in Rett syndrome if it is suspected. Now let me here revise the features of Rett syndrome. It is basically apparent after 6 to 18 months of age. It is almost exclusively seen in females, and clinical features are overlapping with that of the autism, that this language impairment, coordination impairment, and repetitive movements. So it is a close differential and must be ruled out. A Woods lamp examination is also warranted if the child has signs of tuberous sclerosis because it is coexistent. Woods lamp examination basically makes the hypomelanotic macules of the tuberous sclerosis become more prominent. Now coming on to what is early intervention. Early intervention basically has various models. That is, various kinds of early intervention can be done. It is obviously done by a trained child psychiatrist or psychologist. And these various models can be behavioral models, for example, applied behavioral analysis, structured teaching, for example, treatment and education of autistic and related communication handicapped children or teach, developmental or relationship based models, for example flow time, integrated programs that use a combination of strategies within the treatment program, for example social communication, emotional regulation, and transactional support or CERTs, cognitive behavioral therapy for anger and anxiety management in young adults with autistic spectrum disorder, and pharmacotherapy, which is rather reserved only and only for specific target symptom or comorbid conditions and not for the treatment of autism itself. So, intervention should be begun as early as possible, even while evaluation for a definitive diagnosis is continuing. It should target one of the core features of autism, that is lack of communication, language, and repetitive behaviors. It should be specific, evidence-based, structured, and appropriate to the developmental needs of the child. That is, autism should be recognized as a specific disorder and proper therapy should be instituted. The management is provided through an interdisciplinary team comprising of developmental pediatrician, child neurologist, child psychologist, occupational therapist, speech and language therapist, special educator, nutritionist, social worker, and of course parents. Parent education and home interventions are important, but they alone do not form a substitute to individual therapeutic intervention, and this has to be made very clear to the parents because they may take their child's illness lightly. There is not much scientific evidence as far as outcomes like improved language and communication, improved child initiation and adaptive behavior, and reduced parent stress is concerned if we do only parent-mediated intervention. But there is strong evidence for positive change in patterns of parent-child interaction. Active involvement of families or caregivers is therefore recommended as a part of co-therapy. Parents should help set goals and priorities for the child's treatment and should reinforce new skills at home and in the community when they take the child with them. These interventions do also increase a sense of empowerment on the part of the parents. So, the goals of any intervention model are to enhance eye contact, social orientation, and non-verbal as well as verbal communication, that is reciprocation, reducing the repetitive restrictive behaviors, improving joint attention, and improving social, motor, and behavioral capabilities. A recommended intervention program should preferably have 1:1 or 1:2 child to therapist ratio, individualized for each child. A minimum of 25 hours per week of intervention is critical for the program to be effective, and program should be evaluated ongoing when it is ongoing, and adjustment should be made as and when required. Now, psychopharmacological interventions, as I've already told, it is not meant for treatment of ASD per se, because ASD itself has no pharmacotherapy till date. It is rather for comorbid psychiatric or neurodevelopmental conditions and for specific or target behavioral symptoms that interfere with overall functioning. These should always be used in conjunction with appropriate behavioral and environmental interventions. Like methylphenidate is used for hyperactivity and inattention. It is used when impaired function persists in spite of behavioral and or environmental interventions, but the response rate is lower in children with ASD than in children with ASD with ADHD. Adverse effects include sleep disturbance, decreased appetite, sadness, dullness, and social withdrawal again. Maladaptive behaviors are like irritability, aggression, explosive outbursts, lattice tantrums, and self-injury. These behaviors may occur in response to anxiety or frustration, and if one of these impulse control problem is identified as a cause for the behavior, then medications targeting that problem should be used. Risperidone, an atypical antipsychotic, is the most commonly used drug in this. Positive response in individuals with disruptive behaviors existent with ASD has been seen. However, it does not significantly affect deficit in social interaction or communication. Adverse effects are mild and resolve over a few weeks, and it is recommended in the age group 5 to 16 years of age in the dose of maximum 3 mg per day. Fluoxetine is an important drug, SSRI, that is selective serotonin reuptake inhibitors, which is used for the treatment of repetitive behaviors and rigidity in patients with autistic spectrum disorder. Other drugs used are clomipramine and valproate. SSRIs have fewer side effects and may be helpful in treatment of coexisting anxiety as well. Gastrointestinal problems are treated the same way as in children not having ASD. Sleep disturbances including late onset sleep, frequent waking and restlessness may be related to abnormalities in melatonin, serotonin or GABA. One must rule out obstructive sleep apnea and other sleep disorders and provide behavioral interventions at the first place. It is important to remember that US FDA per se does not approve any medication to address sleep problems in ASD, but still several are used in clinical practice, as has been mentioned in the consensus statement. Melatonin is recommended for patients with ASD who have difficulty falling asleep and staying asleep. Despite appropriate sleep hygiene and behavioral or environmental interventions, a low starting dose 0.5 to 1 mg 30 minutes before sleeping time regardless of age and weight should be given. A maximum dose of 10 mg can be reached. Anxiety is treated with anti-anxiety drugs like buspirone, and depression we use therapy similar to those in children not having ASD. The concept is to start low and go very slow. Factors associated with positive outcomes in children with autistic spectrum disorder, as has been seen in various studies, include presence of joint attention, functional play skills, higher cognitive abilities, mild severity of symptoms, early identification, involvement in intervention, and a move towards inclusion with typical peers. According to the National Trust for the Welfare of Persons with Autism, Cerebral Palsy, Mental Retardation, and Multiple Disabilities Act 1999, various schemes have been made available like Niramaya and Aspiration and Gyan Prabha. And as per a notification issued in April 2016 by the Department of Empowerment of Persons with Disabilities under the Ministry of Social Justice and Empowerment, guidelines have been laid down for the evaluation of autism and procedure for its certification. The IAP expert group till that date recommended ASD to be diagnosed using the DSM-5 and Inclin tools and certified using the ISA, of which a cutoff score of more than equal to 70 was there, as we had seen in an earlier scene. And this is the DSM-5 criteria, which has 4 components: A, B, C, D. A is persistent deficits in social communication. Next is restrictive repetitive patterns of behavior. Then symptoms to be present in early childhood, and symptoms together limit and impair everyday functioning. Certification of disability for persons with autism may be executed by an autism certification medical board constituted by the central or the state government and comprising of clinical or rehabilitation psychologist, a psychiatrist, and a pediatrician or a general physician. So the 10 key points to summarize at the end of this video, I think, are as follows. The earliest symptom of ASD is absence of normal behavior. Screening should be done at 18th and 24th months of age. MCHAT-R is a freely available and user-friendly screening tool. Screen positive should be subject to hearing and comprehensive ASD evaluation. Early intervention should begin simultaneously and child should be followed up after 1 month. Multidisciplinary team should work together for treatment of ASD. The intervention should be individualized. Parent education and home interventions are more likely to be effective if part of a multidisciplinary intervention program. Psychopharmacological interventions do not treat the underlying ASD but can improve the child's functioning and the ability to participate in behavioral interventions. And commonly used drugs are methylphenidate for hyperactivity and inattention, risperidone for maladaptive behaviors, fluoxetine and SSRI for repetitive behaviors and stereotypies, and melatonin for sleep disturbance, as also anxiolytics and antidepressants. Thank you so very much for a patient listening and watching, and please do share the knowledge. Thank you. Thanks a lot.